Good evening. How do you do? My name is Bill John Safwani. I'm a filmmaker. They've said a lot of things about me, but I'm just a filmmaker who tells stories. Who tells stories? Yeah. Yeah. So I'm a filmmaker from Rock Pictures. And I'm very happy to be here. This is wonderful to have this wonderful discussion on healthcare in Kenya 2017, the challenges, the opportunities, and moving forward. I was given a task of responding to say my experience and what I learned about the state of emergency healthcare in Kenya through the process of producing 18 Hours, the movie. I will just want to play the trailer, if it's okay, for those who haven't watched the movie, to at least get a glimpse of, yeah. I'll just talk about something as they are seeing how the trailer will play. So 2 years ago, my friends and I read a story in the Daily Nation written by a journalist called Judith Kilonzo, whose presence I'm very happy to see here. She wrote an article about a paramedic who spent 18 hours at the back of an ambulance trying to save the life of a road crash accident victim who won't be admitted to any hospital due to one or another reason. One hospital is because he didn't have medical cover. In another hospital, they didn't have enough ICU beds. In other hospitals, you have to pay an upfront cash before you get any emergency care services. So this came about when I had also lost a friend of mine from high school whom I studied with. He fell from a building and he was rushed to Kenyatta National Hospital, and the same story. And then luckily he had medical cover, so he was rushed to Aga Khan, but then it was too late. He also passed on. So my friends and I asked ourselves, among this range of events, there were certain things that stood out to us. First of all is the emergency number. Just to ask how many people know of an emergency number they can call in case of an emergency situation. Countable, 1, 2, 3, 4, 5. Let me give you one, 0735 359 359. Yeah, no. Is it okay? Yeah, it's 18 hours. Okay, anyway, I'm not giving you an emergency number. You have to find it out yourself. Anyway, that's the first thing. And just to be sincere, we have every ambulance provider in Kenya has a different number. Yeah. So E+ has a different number to St. John's Ambulance, to different ambulance providers have different numbers. So that was something that came up when we were trying to analyze and see what exactly is going wrong. 2, the issue of medical cover came up, and we were asking ourselves, how many Kenyans have medical cover? How many Kenyans have medical cover which actually can help them in situations of emergency situations, or rather health issues, yeah? How many Kenyans have medical cover? That's another question which I'm leaving for the audience to fill in. Then another thing is something we call bystanders response behavior. basically which talks of what do you do in a situation in an emergency situation. For example, you get somebody has been knocked down by a car, or maybe two cars have collided. What's the first thing you do as a pedestrian, or what we call as a bystander? What should you do? Should you take out your phone and maybe take pictures, or should you call an ambulance? Should you try to pull this person from the wrecked car? What are you supposed to do? Then all these issues tangled around the doctor's strike, the nurses' strike, the clinical worker strike, the ministry, the NHIF issue, the Ministry of Health scandal. We have a range of activities which have happened in 2017 and last year related to healthcare in the country. Then finally, the last question is, how many Kenyans know their right to healthcare, access to emergency healthcare? How many people know of the Kenyan Health Act 2017? What does it state? Yeah. So let me just say that the Kenyan Health Act 2017 says that every Kenyan has the right to access emergency healthcare. So it's your right, whether you have the money or not. You're supposed to access emergency healthcare. 2, any hospital, which either private or public, that doesn't provide emergency care and yet we're in a position to do so, are liable. So these are things that came up. So basically, my team and I decided to make the movie. I wish we could watch the trailer, and we made the movie because film is a mirror to the society. It's a mirror to the society and our humanity. Film actually shows how the society is. It's a change. It's a tool of change. Yeah, film is what we live. It is what we are. And one writer once said that any piece of art that doesn't depict the social milieu of a society is invalid. As Africans, what stories we tell, we need to tell stories that actually have an impact on our society. And right now, healthcare is a very vital case in our country. And making this movie was not an attack to any institution, to the government, or to anybody. It's just to bring up the conversation and help have better healthcare for all. Thank you. Let me just try and play the trailer. Okay, thank you. Thank you very much.
Sorry about that. We always tend to have technical issues when we're trying to have an important discussion, but it's okay. We're going to try and show the trailer afterwards at the end. I think there's a problem with our laptop. So our next panelist is Dr. Wendy Njoya. So please join me in welcoming her.
Good evening. I was asked to answer the question from my experience, what should the role of civil society be in raising health awareness? So I'm going to talk about civil society not as NGOs, but as the group of citizens, the public. And, you know, I'm probably stepping on many academic toes, but please let me work with that definition today. So I think the major role of the civil society is to rally support for public health care. I'm not saying that private healthcare should not operate, but I think our duty as civil society is to public healthcare. And what does supporting public healthcare and also public healthcare workers mean? I think the first one is to fight for the protection of our public services and for the people who are serving in these services, and that means fighting neoliberalism and state capture, and that is something I talked about a lot on my blog. I also think that we need to promote the public sphere in terms of the public, not even just public services in terms of emergency care and treatment at hospitals, but also public space, places to walk, places to relax, especially in the cities, so that people are not forced to always be in cars and to sit for hours and hours in traffic. There should be bike paths. Public transport should be better so that people can be encouraged to leave their cars at home, so that we declog the roads. And that way, when you have public transport, it forces people to walk to the bus stop to get the transport and to walk to their place of work or wherever they are going. And so that is also a public health care issue. Public space and public transport, also places for kids and even adults to play and walk around. I also think our job is to flag private sector interests that are undermining public health care. And that is something I talked a lot about in my blog. And my voice was one of the few. We were about 2 or 3 other people, because the mainstream media was supporting the investors in public health care. But I think this is a role that needs to expand to the rest of the civil society. We need to talk about the companies that are benefiting from and international governments profiting from using our healthcare. I just want to say that in this day and age, the state, we cannot go on the model of the 1990s where the state was the main, it was the main center of our attention as civil society. Now it has gone to private sector, and we need to look at what they're doing. Lastly, I want to say that there needs to be religious and philosophical involvement in articulating why public health care matters. The healing ministries, unfortunately, are undermining health care. And I know this from an experience, because as a cancer patient, the churches basically harassed me. I felt harassed by, basically suggestions that I didn't have faith enough. And that was why I was not getting well. In fact, some Sundays I would go to church and you'd get the impression that I'm not supposed to go for my chemo the next day. So I think the church needs to be roped in and given a theology of public health care, because healing ministry is undermining public health care. The same thing with philosophy. We need, we are talking about rights, but rights has such a combative element, and we need an African philosophical worldview of why healthcare matters, and why it is not only that African societies have had doctors, not uchawi, and that healthcare has always been a service that we have been given. It's not about Western medicine and African medicine. It's about help. It's about help for the ailing, and that's what public health care should be. So there are many other sectors I could cover, but I think those are the main things that I thought about when I was thinking about what civil society can do for public health care. Thank you very much.
Thank you, Dr. Wandia, for your talk. Our next panelist is John Gilongo. Please help me in introducing him.
Good evening. Both Wandia and Bwana Afwani raised the issue and focused on the issue which I think is at the heart of Kenya's healthcare delivery system, which is the constitutional, essentially the constitutional demand that is placed upon us as a society and the government that we elect to deliver for the vast majority of Kenyans, basically emergency care, and those who can't afford health care, a social security system that provides it to them. And when you sit back and think of the implications of this, then I can begin to process a question that I was asked to answer, which is, what is the impact essentially of corruption and bad governance and mismanagement on the delivery of healthcare in Kenya? So I'll talk from an anti-corruption approach, but also present to you for discussion examples from Kenya of where the delivery of health as a social service has worked, in my opinion, and I'm happy to be criticized. I'm not an expert on healthcare, but corruption, or should I say anti-corruption. So, Article 43 on economic and social rights constitutionally guarantees healthcare via social security, via our government, or governments, so they talk about the counties, for those who can't afford it. And I think we can accept that as Kenyans, that means the majority of Kenyans. So we talk about this system of delivery through social services, we're talking for the majority of our population, and that's just the reality. And I said it's got implications for service delivery. The little research that I've been involved in terms of anti-corruption and how it affects healthcare, and I'll emphasize that whether you talk about mismanagement, in an environment like ours where we have systemic corruption, and by that I'm talking about the countries that are bottom 25% of the Corruption Perception Index of Transparency International, you'll find that corruption will affect certain sectors predominantly, and this is not dependent on politics or any other consideration. It's just the reality. Health is one of them. Big line ministries, health, education, public works, defense, and then the big tax collection agencies that have, by law, the ability to tax your salary, whether you have any recourse. Without any recourse, you cannot refuse to pay your pay as you earn, your NSSF, your NHIF. That is deducted from any check that you get from anyone who's paying you for your services. And these institutions are usually the ones that are most heavily impacted by corruption. And it has a disproportionate impact on women. The less educated you are, the heavier the impact on you, and the poor. Those are the most heavily impacted. So I think the constitutional provision that we have in Kenya, in our 2010 constitution, actually serves those who are most heavily impacted by corruption as it affects the delivery of the most important public services like health and education and the like. It has another effect when you have systemic corruption in a society like Kenya or any other society that has this problem, and that is it undermines the ability of policymakers to make policy. It undermines the very legitimacy of politics when the population comes to believe that corruption has infected the way services are delivered, the basic services, health, education, security, and the like. And this has a very major distortionary effect on policy. People may want one thing, but they'll opt for much less. So, when you talk of private solutions for public problems, that kicks in, whether it is in education, in terms of delivery of education services by government, health, and the like. So it undermines the ability, and politics is important. We said we won't focus on it very much, but politics essentially solves problems in society. And when it starts to fail, people look for other measures, which is always destabilizing. I had a chance to have a conversation with some colleagues from Makueni, and you are experts in health. I'm not, but I thought I'll just throw some data at you to get your opinion on what's happened in Makueni, which shows what can be done with a little bit of political will and some integrity. Now, Makueni used to spend on drugs and treatment just for health. 2014, 2015, used to spend about 300 million shillings. Makueni is a county, about 1 million people in all the constituencies in Makueni. And in 2016, they had fully implemented a universal healthcare program. And I'm not going to including the amount of money they spent in just public works, in building up their hospitals and that kind of thing, but what it took just to manage them, to pay for the drugs and to give these 1 million people free universal healthcare. And the figure just increased by 50 million shillings. from 300 to 350 million shillings. So, for me, the question I asked the governor and others, I said, okay, where was that money going? If you're now able to give free healthcare to 1 million people and you are spending 300 million shillings and you weren't delivering even a fraction of that. It's a good question, and I'll throw it to you. I think you'll be able to answer it better than me. In 3 years from the implementation of the Universal Healthcare Program, from around 2013 until now this year, Makueni has built more hospitals and dispensaries than were built in the entire period from independence until 2013. So in 2013, Makueni had about 115 health facilities, and between 2013 and this year, right now, they have built 125 facilities. So again, the question I asked them, how come you're able to do this? And Makueni is not a big, major, super wealthy county, but they've been able to deliver healthcare to their people, and in a sense meet the constitutional obligations that are placed on all of us. Again, a question that is interesting for you to ponder. Makueni County the entire region has got 9 major hospitals, and over the last 2.5 years, each of these key hospitals has a theatre, a fully functioning operating theatre, and a maternity facility. Again, fully functioning and working. And this is all within that 350 million shillings that used to be spent only on drugs and basic delivery. And each of these 9 hospitals also has a moving lab for wananchi, so people can take their specimens and be tested for basic things like malaria and the like using this lab. In the county headquarters of Wote, they've even built a gas plant. So they're manufacturing oxygen, which can be put into tanks, and they're now exporting it to other counties, which I found to be a very interesting development. And Makindu, as most of you who've driven on the Mombasa-Nairobi road, it's a major killer of Kenyans. There's a lot of mobility. And again, here in response to this, they've built a trauma center just for emergencies in Makindu. I want to leave it there and ask you the questions as people who are in this sector. How come this county has been able to deliver? I'm not saying what they've delivered is perfect, but they've been able to meet their constitutional obligations to the majority of our population using just 50 million shillings more. Now, 50 million shillings is I won't compare it to anything, but it's 1 day of theft in certain offices, isn't it? We read about it in newspapers every day, so think about it and just factor in what can be delivered with that amount of money. Thank you very much.
Thank you, John. Our next speaker is Willisesta Bahati Ondimu. Please help me in welcoming her.
Good evening once again. Good evening. My name is Wilkista Bahati Ondimu, and for the purpose of this discussion and probably interaction, I would prefer that we use Bahati because it's a little bit easier. I'm a medical social worker at Kenyatta National Hospital, and my experience as a medical social worker, it has revealed to me that indeed our society is experiencing a lot of challenges because the vulnerable groups have increased tremendously. Because of the changes in population dynamics, we are experiencing population growth. Like at the moment, the last survey that was done in Kenya, we realized that we are at 48.5 million, and that also translates to the level of poverty because in any society the resources are always limited. So we don't have enough to spend and address to the issues adequately. Now, probably I would also want to take just a brief a short moment to maybe to enlighten some of the guests around what medical social work is all about, because as I was waiting for the meeting to start, one of the guests asked me what is all about medical social work. Probably you have heard about social work. It's a helping profession. It's geared towards empowering clients to cope with the situations that they find themselves in. These clients, usually they are very vulnerable. They have experienced maybe some level of trauma, or something has changed in their life, maybe all of a sudden, and they're experiencing a lot of stress, such that they need help. They need somebody to work with them, especially psychosocially, so that they are able to cope with the new state of life. Now, when it comes to medical social work, we are that subset of social work fraternity, but our practice is usually done at the clinical side. We are based in the hospitals. So in the hospital setup, we give that complete psychosocial therapy to our clients, which ranges from, it starts from getting to know who the clients are through the evaluation. And then from there, we do needs identification, which we address accordingly, depending on the needs of the clients. Now, the assignment that I was given is regarding the public health care insurance. And in our setup, the only public health care insurance that we have at the moment is NHIF. NHIF is government sponsored. It's perceived to be the cheapest way of subscribing to, so that we can get a medical cover. Initially, the customers used to subscribe at a rate of 160. Sometimes back it was raised to 500 for the self-contributors. And with that, NHIF promised the public that we can access medical health from whichever facility of our choice, and they did different capitations to the hospitals of choice. But again, with that came a challenge whereby when the client is requested to fill in which hospital of choice they will be receiving the treatment, some of those health facilities probably they don't have all the required medical interventions, and that leads them to being referred to a higher facility like Kenyatta National Hospital, of which when they are referred, Kenyatta National Hospital is not one of the hospitals that NHIF takes care of, especially in outpatient care. So it's really a challenge to especially the customers who are self-contributors, because whenever they require to come for treatment in a higher facility like Kenyatta National Hospital, they are meant to pay. Another challenge that I found out from our public health insurance, NHIF, it has limitations when it comes to remitting or giving remitting the funds to the health facilities, because they have packages, different packages with they have controls. But on consultation, I went further to find out how they go about it. I was informed that, for instance, maybe I can give you an example of radiotherapy. And maybe a patient may be required to have, let's say, maybe 35 sessions of radiotherapy. But NHIF would take care of 20. And the remaining ones, maybe the patient to address that. That prompted me to find more about it. Why so? And the response I got is that in any institution they always have a challenge in resources. So if every patient is to be given all the due attention that is required, they may not be able to give it to the rest. So they have come up with the different packages, different rates to assist the public. And when it comes to accessibility, as a social worker in the hospital, I've realized that some patients, when they come, if they don't notify NHIF within 24 hours, even if they are fully subscribed to the scheme, and their cards are up to date, NHIF is likely to decline the payment. So still they will end up paying cash. So that was really a challenge, and we are pursuing the issue so that probably they can be able to give better services to the public. That's what I found out.
Thank you, Bahati, for your presentation. I'm going to learn your name by the end of the day. I have to. Do you mind saying it again, Willie? No, yes. Do you prefer being called Bahati? Yes. Oh, you prefer? Okay, sawa, no problem. Okay. So our last but not least presenter is Stephen Rutere. Please join us in welcoming Stephen.
Okay, thank you, brothers and sisters. In our industry, we refer you as brothers and sisters. So, as you learned, my name is Rutere. I'm representing our General Secretary. Generally, today's topic, which I will cover, was about the role of trade unions, and specifically the Canaan. I come from the Nurses Union. Maybe most of the Kenyans understand and have come across our activities in the streets. When many of the citizens, of the people, hear about trade unions, they see unrest. But it's not exactly that. It doesn't mean unrest always. But we mean good for the citizens and the employers. In fact, when employers see us or hear about unions, they shy away. They don't want to deal with unions. But unions, the role of union in every development, in the health sector or any other economy, is well known from the time immemorial, because it is agitation of the right. You have already heard of the right to health care in the Constitution. That is Article 43 of the Constitution. The right to health care. And you might ask yourself this question: why does the government don't teach you about rights in the curriculum? Why? Who has an answer? Because when we go on the streets to agitate for the rights, we don't only agitate for the rights of our members. We also talk about the rights of the citizens. Because we don't only argue about our salary increments, we also forward grievances which touch or benefit the normal, the common mwananchi. That is provision of better services, like when we ask for more employment of more nurses in the hospitals. It will be easier for every Kenyan to visit our hospital and take the retro, the retro, few minutes in the hospital, when we have many nurses in the hospital, or healthcare, or doctors, any healthcare service or offered in the hospital, than when you have few workers in the hospital. So don't view us as if we are agitating for our rights only. So I have only 5 points to emulate. One, we participate in health policies, formulation of health policies at the national level. We are stakeholders in formulation of policies. For example, we have the Nurses Act. The Nurses Union is a stakeholder and has to be involved always. Those who can maybe Google can know, can go ahead and see what the Nurses Act, Cap 257, talks about. It is in the internet. So it talks about provision of better health services for mwananchi. So we do that. Then we take part also in formulation of NHIF policies. We are a stakeholder and we must be included. If we are not, then we petition. That is our work, because it has to bring out the picture or the required result to our members and finally to the Kenyans. Then we also participate in the Public Service Commission policy making. Those are human resource policies. Also, we participate in the formulation of authorities, coming up with authorities at the Employment and Labor Relations Court. I personally am trained as an industrial relations officer, and I present cases in court for our members. So once we get an authority, it is used to engage or to at least guide in the industrial in the industry, because our main aim is industrial relations with employers. The other thing that we do is to lobby for funding in provision of health care. For example, the Abuja Declaration, where African countries, heads of states in 2001 came up and pledged on allocating or budgeting 15% of its annual budgetary budget to health care. Up to date, we have not acquired that, but we are still continuing to pressurize the government to at least do that through provision of more equipment, standard equipment, more drugs. Like when we go to the streets, we also ask for government to give us working tools, not only salaries. So when we get the tools, at least the citizens get the services. The other area that we do is protect our members. We represent our members in OSHE, that is WIBA, that is Works, Injury and Benefits. In our hospital setup, the employer has to provide a safe working environment, and not only for the members of our union, but also for you as a client while visiting the hospital. That's why you'll see safety measures everywhere, and the work of our union or our shop steward in any institution is to ensure that the members also enjoy those rights. So the other thing is that we agitate for employment of more, as I've mentioned, of more nurses and in general or other employees, because the nurses cannot work in isolation. If there is no driver for an ambulance, really, will the nurse work? So we also agitate for that. We need a clean environment. We agitate also for employment of adequate staffing, that is the sweepers, all the staffing in the institution. The other one is now where it comes to better remuneration for our members. Now, the role in advancing health care or helping advance health care in that point is when you have a motivated staff. This staff, in the form of monetary gains, will be happy to serve the client. And that is our main objective, to sustain our members. But all it trickles down to the citizens. Because when I am fully taken care of by the employer, the end result is the client, and they will go home satisfied. My last point is also training. When we train our members on how to take care of themselves, we also train them on how to take care of the clients. We hold seminars for them, continuous medical education seminars, and we also give them knowledge on how to take care of the customers. That is customer care. We partner with KOTU, which is our umbrella body, to also sensitize even the members of public. You have seen billboards everywhere. And this is where we appeal to all employers that they should not shy away from unions. Where unions are involved has been seen to have an improvement in delivery of services. That is, productivity is higher because unions act as a mediator in between the worker and the employer. And this, where there is a good relations between the employers and the employees, there is little or no unrest or disturbance in service delivery. Otherwise, that's the little I earned, and thank you.
Thank you, Stephen, for your talk, and thank you to all our panelists for your talks as well. We now come to the Q&A session of the panel discussion. But before we do that, I want to take the opportunity to introduce a couple of people who have just come late, or who have come, but I unfortunately wasn't able to introduce. I apologize for that. We have Dr. Machonda Chibanzi, who is the Deputy, please stand up, Deputy Secretary General of the KMPDU. We also have Dr. Samuel Kigondu, please stand up, of KMPDU. Yes, clap. Thank you. Thank you. We have Eunice Kilonzo of Daily Nation. Please stand up, Eunice. Thank you. We have Mr. Moses Lore. Is he here? No. We've already introduced Brian Odihambo. We also have, is Dr. Nelly Bosire here? No? Okay, so those are special guests. So, moving on to the Q&A session. And I'll start with the first question, and then if you can, the microphone. So the microphone is just behind with Benja, so if anyone has a questions, please raise your hands. So my first question is, I see throughout all your presentations that there's this theme of all of you in one way or another advocating for better healthcare, whether it's through film, whether it's through academia, blogs, governance, or even working on the ground. You're all in one way or another advocating for better healthcare. In your opinions, what do you think the challenges are in actually getting people, and when I mean people, I don't just necessarily mean government, because I'm guessing there's many stakeholders, but what are the challenges that you face in being able to actually push through on that healthcare agenda? Is it just that there's this culture of apathy? Are people just not, passionate anymore about improving healthcare? Are they tired? Is there an issue with the government? Are they not taking it seriously? What is the issue in your opinion? And then after that question, pass on the Q&A to the audience members. Thank you. Who would like to start?
So I think you've done a great job in terms of explaining who's actually there, from filmmakers to anti-corruption crusaders, nurses, and academics. I think it's great. So I have two questions, and two areas perhaps for academic and activist interest. The first is, we know by the statistics that something like about 20 women die in childbirth, and there's become a resurgence in what I call mothers in detention. Women who give birth and are detained with either their dead fetuses or with babies, There have been 16 since the beginning of this year. I think now they're actually 18 since I looked at this a month ago. Is there not something we can do about this to make this an issue of academic research and public policy interest? But also, is there not something we can do more practically to actually get these people who are detained in our hospitals out of incarceration? Second question is related to a study that's just come out. I think it was released today by Twaweza. And it's called Striking an Unhealthy Note. And they do these random opinion surveys. And there are a couple of stats that I think are kind of interesting for us to look at. One is there has been a 27% drop in the access of citizens to public health care. And twice as many people are now using private health care compared to last year. Right? Now, given what we know about the labor strikes and the industrial action and all this that's happened this year, are we not seeing a creeping privatization of our health services, not just in terms of the shift of health investment, but actually that people are beginning to go for private health care rather than public health care? And should this not be worrying us?
Okay, so we allowed the panelists to answer. Also, if anyone has an answer, there's a conversation. So if you have an answer to the questions that are asked, please do call me and I'll bring you the mic. Anyone here?
Okay, why are people apathetic to public health care? And for me, the answer is simple. It's the ideology of private solutions. So the idea that we can solve all public problems privately has been sold to us for 20 years. It needs somebody to do the research because it's a creeping villainy, meaning that it started very slowly, but then it started getting momentum under the Kibaki administration. And then by the time we entered the Muigai administration, then it just hit the roof. So this ideology has been very strong, and it is only now, unfortunately, that some of us in academia are realizing that the warnings had been being given in the US and the UK and Australia as early as 20 years ago. But because the state of our universities is so bad, we did not know what was happening until, I think, about 5 years ago. And even up to now, the African Academy is not talking much about this, which is very unfortunate. Twice as many people. Oh my God, sorry, I'm very emotional about healthcare. That is so horrifying. But I want to say, which was what I said in my article on New Year's Day, that this was planned. It is not an accident that people are rushing to private healthcare. That was the plan all along. Last year, I quoted this article, which was in the New York Times. I said that the private sector was going to undermine public healthcare so that people, as a way of advertising private healthcare. So it is not surprising, and now my worry is that we are going to blame the unions for this event, and it's not the union's fault, because as early as 2015, the newspapers were reporting that there was a plan to defund public education so that the private hospitals can get healthcare workers from the public sector. So this is just horrifying. I am so horrified, but it was planned, and let no one blame the unions, because this has nothing to do with the unions. This has to do with private sector privatizing public hospitals.
Sure.
Maybe I can add on that. The challenges, at least I'm happy that the union is getting a relief that we are not the cause of the problems. Because when you see us crying on the streets, we expect the citizens also to join hands with us to ask for their right as provided for by the Constitution. But when we go out there, we don't go out there willingly. We try to engage the government, which is very irresponsive. One, we have a problem with the Ministry of Labor. Ministry of Labor is a big challenge. It is the one which should handle all the workforce in the whole country, but it is not funded. Where does the funds, where are they supposed to get the funds from? The Treasury. We should allocate the funds even to take care of the staffing there. When you have an issue, even in the private sector, if an employee has an issue even in the private sector, because the unions also get into have membership in the private sector, you will take changes for that problem to be settled, because there are no employees in that building, NSSF building. They are based in NSSF at the Nyayo House, but there are no employees. We have also those labor officers working at the county level, but sometimes there is nobody in that office for almost a month or even weeks. So we have a challenge, but it is very unfortunate that we have an irresponsive government, and that's why we should also join hands to demand for our rights. I've asked you a question that why does the government don't teach people in the curriculum about your rights? Because it is easier to manage people who don't know what their rights are. So if we are suggesting, by the way, in most of our meetings, forums, that the curriculum, the constitution being introduced in the curriculum from the primary level or in the grassroots, even in the social forums, that we have to present these rights and make the citizens know about their rights. Thank you.
Dr. Kigondo is my name. I carry many hats. But I'm the photographer of the union. So if you go to my YouTube page, you'll find the strike from day one till the last day. And I believe in what he has said in terms of filming being the reflection of society. And when we started the strike, the doctor strike, it was a very strike. And I think the doctors brought humanity back into the Kenyan society, which was lost partly because of fear of politics. I can safely say that I'm now old, so I don't fear dying. So I can shout, get hijacked, killed, but my children should not suffer poor health. I've been in the public sector and the private sector for long to know that what Wandia is saying, that privatization of public health is the problem. Why do I say this? In the constitution making process, Kenya Medical Association put in the public, what is it called? The Health Service Commission. Now, for the public, the Health Service Commission is very important for the public, but the politicians will never tell you this. What does it mean? It means that the public sector will have the highest level of medical workers because it is governed by how do I put it? Medics are the only ones who would know what medics are. The problem we are having people sitting on tables, an accountant trying to assess what a nurse can do, what a doctor can do, but they can't. So for instance, you'll find ridiculous things like he's telling the doctor, you have to sit on the table from 8 to 5. That's not the work of a doctor. The doctor, for instance, or an easier example is, a doctor, they come and tell you have to do 10 surgeries. Yeah? So when you tell that to a surgeon, let me give you an example. A surgeon, for him to do 10 surgeries, he can come and remove 10 small things there and list them as 10. But that surgeon who goes in for a hard operation for 8 hours, he has done how many? 1. But he has saved the technical ability for him to do that 1 cannot be measured by the 10 that other person. So only a doctor would be able to measure all the health professionals. Now, what was the effect of unconstitutional devolution of health? It was the elimination of the public sector. And I have a feeling that it was the private sector who paid for it to be removed. Why? Because if you have good doctors, nurses in the health sector, then the cost of hiring a doctor, a nurse in the private sector is higher because people tend to move towards them. And the effect of that is that you now are not able to employ. Like, for instance, it'll even get worse because now they have stopped hiring doctors and they have told them, go to the governor and look for a job. Previously, it was autonomic. So in the next 5 years, your health will go down and the cost expenses will come up. The solution was the Health Service Commission, because it can manage health and keep the public health well. The private sector is not supposed to profit from a collapsed public health system, as has happened in what he has said. It's supposed to provide higher level of medicine, keyhole surgery of some neuron that is lost. But treatment of 1,000 people should not come at the expense by a private sector. And if you look, and I was just telling Newton here, if you now look at who the owners of the middle-level hospitals are now, they are privateers who have purchased the mid-level, because the public health sector had collapsed, people had to go to the sort of middle level and even the high level, so they've been purchased. So privatization of health is what we have done. And finally, the problem with the public is that they believe the politician over the doctor. Yeah? And I'll give you an example. Recently, you saw in the news, the governor of Murang'a County comes and dresses down hard-working public doctors and tells them, they are stealing from the pharmacy because he has been told by his constituent that there are no drugs in the pharmacy. So he comes and in public dresses down the pharmacist, dresses down the medical superintendent, and tells them he'll fire them. So what in effect that does, it makes the professional look bad and the politician look nice. Yet, if you look behind the scene, probably, not that I'm saying, he's the one who has not paid the suppliers to bring the drugs. You get the point. So there's a disconnect between the public understanding how the politician affects the professional and supplies in the hospital, because he's just told, no, look, these doctors are stealing. I mean, there's no proof. You cannot, but they believe because they voted for it. So I think, I don't know, it's difficult, but for me, the urgent solutions for people is that we need a health service commission that will really boost health sector. This thing of being told counties, Makueni is, I agree with you, a good county, but it's 1 of 47. You see, another example is that, for instance, a governor has only 5 years. Yeah? It is not in his interest to pay for a neurosurgeon to be trained, because the neurosurgeon will take 6 years. Yeah, that for him. Therefore, when you say that health is devolved, then that in effect means you never get a neurosurgeon. It's not him training is a waste of money to train a neurosurgeon. You get what I mean? And there are bigger issues. I can talk forever, but I think I let the others.
Anyone has a comment, a question?
Okay. My name is Abdulaziz. I'm from Pathologist Lancet, Kenya. I sit in the KHF PPP committee. And before we raise this question, I wanted to, from the presentation from the various speakers I've had, focus is mainly on government. And it has clearly come out from Dr. Kingundu's presentation. What I was wondering is, don't you think there's a point of convergence between the public and private sector? I wanted to ask that, and Kingundu brought it out clearly. He doesn't seem to think so. Having come from Lancet, I can attest to the fact that there's a PPP model which is currently being prompted, and it started during Kibaki's time. That's when it started gaining ground. And I know of places, a few counties, whereby the public and private sector have come together to offer services which have been beneficial due to economies of scale. It's not necessarily always about profit from the private sector. That's what I can say. We have empirical evidence to prove that. Voi County is one of the places where Lancet is, and the numbers have actually gone up in terms of revenue for that hospital. We went there, set up a lab. The prices of the charges have actually gone down. So my point is that public-private partnerships indeed can work, and the motive always isn't for profiteering in the private sector, and we need to have a research-based approach to tackling the various healthcare issues that we have. Thank you.
My name is Dr. Mwachenda. I'm the Deputy Secretary General of the Doctors Union. Well, they've said a lot of probably what I was also going to say, but I'd like to insist that, and I always say this whenever I have a discussion on healthcare, look at the education system in Kenya. Compare the education system in the 80s and now. I believe majority in the 80s went to public schools and they gave quality education. And there was a systematic way of killing the public education system and setting up a private education system. And it has happened to an extent that today in Kenya, anyone who has a good job, I call them the middle class, they believe that their children should only go to private schools. They cannot take their children to public schools. Now, that happened to education. That is happening to healthcare right now. It's the same thing, same script. So, Kenyans are apathetic because, one, when you go to a public healthcare, public facility, you will not receive quality education, and quality health. And I don't mean that you don't have good doctors. We're the doctors who are trained in the universities in Kenya. Quite a number of us leave the country, and out there, Kenya is rated as one of the country which produces quite good doctors. The issue is that the patient will come, I'll see the patient, I'll send the patient for a test, basic tests, blood count. I'd probably want to do some hormonal levels. The laboratory in the public facility is unable to do that. So now you're left to tell the patient, go to Lancet, go to this other, you understand? So when they get there, outside, I like the private partnership that he's talked about, but outside there, the labs that have been set up, that are private labs, are charging off the roof. So what's the point of the Kenyan coming to a public facility, going outside that facility for an X-ray, for a CT scan, for an MRI, for every single test that the doctor wants, and then come back to this facility for now a complete diagnosis and treatment? Does it make sense? It doesn't. And you see, that's why Kenyans have slowly left the public facilities. The Kenyans who access public facilities, and I can tell you for sure, and there's something we're trying to work on, we'll probably launch it next year, most of you will cry. The patients I deal with just this week where I work are patients who I'm bargaining with them on their health. I have to bargain with them on, I want this test. A patient has a stroke, they cannot afford a CT scan. So I have to start bargaining with them to treat this patient just on the clinical symptoms and signs that this patient has a stroke and I don't have a CT scan, and him buying his medication. The number of tests that I require, I have to bargain with them. It's disheartening. And that is what is happening in the public healthcare system. We have a so-called middle class. The WHO launched what is called Towards Universal Health Coverage, a call to action. It was sometime in May, and during the UN General Assembly in September, it was discussed. And just recently, there was a conference in Dublin, Ireland, on health for human resources for health. And what is it saying? In essence, political will is the key to unlocking universal health coverage. Kenya is not any different. The day we will have a government in place that will think of these Kenyans who cannot afford who cannot afford quality healthcare in the private sector is the day the wheel will turn towards quality healthcare in the public sector. During our strike, a cabinet secretary, Treasury, on TV confessed that what happens if we pay doctors in the public healthcare, well, you will have an efflux of doctors from the private sector into the public sector. So that tells you that the private sector has interests. I'm not discrediting the private sector. What I'm trying to say is that it's playing a very big role in the current state. What Lancet is done, and I can attest to it, I've seen it in Voi myself. What Lancet has done is something that is good. What we need, because the advances in healthcare, unfortunately the public healthcare cannot offer that. The advances that the private health sector offers is a good thing for the country. But there has to be a balance. Without a balance, we are killing the public health sector. Things like embolization, cardiac angiography, where people, you take into theater if you have attack and the clot is just being picked off your system and you're fine. These are good things. They're being done in the high-end facilities. But unless there's a mechanism for which even the normal person can access that, then our public healthcare system is going down the drain, and there's no one else to stand up for it except us. It's not just the unions, it's not just the academicians, not just the filmmakers, it's every single Kenyan. If I may just finish with a story that the WHO has captured in its report, and I'd like you to go to the website and download it. It tells of a story of Robert, who has a good job. His children go to a very good school. Essentially, his wife, his family have a good medical cover. And then one day, Robert realizes that while doing his morning jog, he's unable to cover the same distance. He's feeling tired. And then he starts feeling weak. He develops weakness. He goes to a facility and is diagnosed with cancer. And then things go downhill from there. So Robert is told that for you to access good medication and treatment, the cost is this much, which is in millions of dollars. The insurance pulls out. So Robert now has to make a choice between going for his savings, for his treatment. It's cancer. The doctors are telling him you have at most 2 years. So eventually, Robert makes a decision and decides that I will just do supportive. The definitive for the cancer, let it stay, let my family stay, at least with something that will take them through time. And within a year, Robert dies. This is a story in the WHO report. So that tells you how many of us in Kenya in Robert's situation. That's the reality. The insurance you have will not help you. If anything happens, emergency, you also what happened to the late governor, Emiri, unfortunately, because the first facility that could sort him out was our public healthcare facility. It was not a private healthcare facility. So by the time of being airlifted to a private facility, it might be a bit too late. So healthcare is something that all of us should be very keen on, and we should take it upon ourselves to make sure that we bring this discussion and this agitation that some of us have had, even gone to jail for. It's time that Kenyans now started thinking along those lines and taking it upon them that we make sure that we will discuss our healthcare and protect the public healthcare system. Believe it or not, we have two functions in Kenya. I always say this, that you have a public section of the public that goes to the private facilities. They have no idea what a public healthcare facility. You've never walked into it. I mean, my brother in 2013 walked into one and he called me. I was like, this is how it is. I told him, yes, that's how bad it is. And you have this facility, this section of the public that purely depends on the public healthcare facility. Yeah, I'll finish up now.
Please stand up, say your name, affiliation, and a quick question for our panelists.
Oh, is it me? Okay. Hi, I'm the former suspended director of the British Institute in Eastern Africa, so I'm here in my independent capacity. I'm listening to what we're talking about here, and I guess the point, two things I really want to raise. First of all, this is not a peculiar Kenyan problem. This is a problem everywhere, and this is a problem of neoliberal economics. Yeah, and in fact, in some ways, the question that I'm interested in is what this has to say about what kind of state we have, what kind of social contract we're interested in, right? Everywhere the welfare state, as it once existed, is under attack, right? Kenya, perhaps, is ahead of everybody else, because I'm not sure that Kenya ever had a welfare state, actually. And correct me if I'm wrong. I've been here, almost 4 years, and I'm looking for a Kenyan socialist, and there aren't any, or there aren't not enough of them. It's very hard to even get a whiff of socialism in Kenya. It's the most ruthlessly capitalist country I've ever lived in. Right? But the problem with a kind of neoliberal state, this is an idea of a state that is very small. A state that doesn't provide welfare, a state that provides regulation only. Right? This is a state that protects the rich and it protects capital. Right? And therefore it often leads to massive inequality. And so there are many theorists, international theorists, now talking about how after since 2008, actually Europe, North America is going to look more like the South, right? Very famous book called Theories from the South, which talks about this. Right? But my question really is, how does this link to the language of rights? Because the language of rights, of human rights as we know it now, really emerged in the late 1990s. Right? Exactly the same time as structural adjustment came around everywhere. So is the language of rights aligned with a welfarist idea of the state? Or is the language of human rights really aligned with a kind of small regulatory state that doesn't provide welfare? Now, my understanding of this is that actually the language of rights that's being used everywhere, especially by a lot of international NGOs promoting democracy, for example, is not a language of rights that's about welfare. It's a language of rights that's about regulation. And therefore, we started today talking about the constitutional, the law, the legislation passed last year, which says that every Kenyan has a right to healthcare. Is that really a useful way to progress towards a kind of welfare approach to healthcare? That's my question.
Thank you, panelists. My name is Omolo. I'm a program coordinator with USAID. And the points that are being discussed here are very important. And they are touching me a lot. I will start with cholera, for example. Cholera means you have eaten feces. As simple as such. And in good amount to cause an infection. What are we talking about? Our public system. I had the MC saying that this is a public health something? A researcher, not a practitioner. So it means therefore that our public health system has failed completely. We have public health officers who work from shop to shop, restaurant to restaurant, to collect bribes. It pains me. That is very cholera, 21st century. We should be talking of, cancers, hypertension. We have diseases also in centuries. So I see cholera in high-end hotels, which I have escaped, thanks to God, twice, and I say hallelujah. NHF is another kind of bullshit. Why do we put capita medications. You want to tell me that I can only get sick 4 times in a year? I come from Nyanza, for example. So you are going to pay that money in Homa Bay District Hospital while my job entails traveling in the country. So if I fall sick in Voi, I have to be taken to Homa Bay because I need to enjoy the NHIF. They should sit down. What the minister did to reverse the decision of the CEO is not even in practice because people are still being told blah, 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 blah about NHIF. Coming to corruption. And Githongo John, I've known you for a long time, as a champion of corruption. We've developed corruption. I mean, fighter. You're a champion, you're a fighter of corruption. A slip of the tongue. You have been in the forefront of fighting corruption in this case. And I was in a forum and somebody was cheating actually, that you medical people, what came to your mind? If police officers, people who have not gone to school that much, could sit down and come up with a police service, what is it, commission? Oversight. No, leave alone oversight. We have National Police Service. Was it there before? It never used to be there. But doctors, what happened? That we could not come up with a health service commission to take care of human resource aspect, so that we leave those dilapidated buildings for the governors to take care of. If they want to manage the buildings, let it be so that we manage the human resource aspect centrally, then we can have a working system, just like the teachers. Teachers only complain of salaries, but they are comfortable. Yes. Another thing probably that I would, you gave a good example of Makueni, and I don't know, Mr. Githongo and team, how we can come up as medical people and push this thing to come up with a health service commission. If it is a forum, if it is a people's assembly, if it is a system, any form of a thing that will come up, because this is the only solution to the problems within the health sector. In my duty, for example, I was reading an article that during the strike that was of course legal, almost 0.5 million babies missed their immunizations. We are staring at polio, we are staring at meningitis, we are staring at pneumonia infections. During the same period, for example, today I was handling some other cases that babies are still getting mother-to-child transmission because of the strike that was legal, and these babies are going to be put on medication throughout their lives. While other countries are trying, I was reading Cuba is almost doing a final, almost eliminating the mother-to-child transmission of HIV virus. While Kenya, we are still having infections because mothers do not attend antenatal. I don't know what. I think these are things that we still need to have these discussions, but we need a health service commission. We have so many healthcare practitioners. I saw a medical practitioner, a medical officer yesterday, knocking a private facility looking for a job. And I was like, how? Somebody has been trained for 6 years with a degree, that is knowledge being wasted. They are working. Doctors are not known to walk. They are supposed to drive. But we have a situation where a doctor has to use a motorbike to reach the facility. The worst is they're not employed. We have nurses that are not employed. We have clinical officers that are not employed. And our facilities do not have staff. You have been told to go to the county to get a job? No bullshit. I think we need to sit down, and the starting point is we need to fight the corruption in the counties. We are all Kenyans. We need a health service commission now. Thank you.
I will encourage everyone to keep their question or comment short and sweet, please, so we can get as many people to comment as possible.
Thank you. My name is Nyambura, and I'm a medical student at the University of Nairobi. Thank you for the great discussion that's going on. I have 2 questions. My first one is to Dr. Wandia Njoya. So it seems like we all know the issues and the solutions to the issues, because everyone is giving us a powerful speech about what we should do, So my question is, how do you build a civil society for healthcare that's not viewed as an enemy to policy, but rather than a friend, so that you're not just creating a buzz around issues and making noise, but then, you know, your advocacy is meaningful, you know. Then my second question is to Stephen. I'm interested in knowing whether you think that it's a problem that the human resources for health, and I'm glad that there's a representative here from KMPDU, are working in silos. So everyone is kind of having their own fight, the nurses, the clinical officers, the doctors. Next we'll have the community health workers, you know. So don't you think it's counterproductive what you're doing, instead of uniting and, you know, all talking against all the issues that are happening? Thank you.
We'll have those around so that the panelists have time to answer, and then we'll just start the questions.
Okay, that's a very good question, and we have already started the journey. My brother here can attest to that. We are trying now to see, you see, the trained industry, the trained unionism industry is a legal entity already entrenched in the Constitution and Article 41 of the Constitution. We have started the journey to see whether, and at least do exactly what you are proposing, to have all the workers or the employees in the health sector, not only Mendix, but every worker in a health setup who contributes to the health or to the delivery of services in that institution, at least we speak one voice. Because if a client comes to an hospital, you are not only attended by the doctor or a nurse. So we have started already that journey, and soon maybe we shall have even to achieve what our brother down there mentioning about cholera. How we can even bring over the public health sector. The public health services to their life, because right now we don't have them. When you go to Kenyatta Hospital, at the gate, sometimes they used even to cook at the gate there. Kiveri yapo kwa gate, na ni hospitali, a national hospital. So you wonder, what is this? It is still not there. It is still there, I'm told, because it's 4 years since I got out of Kenyatta National Hospital. So it is serious.
As for my case, I would like to respond to Mr. Omolo, who talked of cholera and NHIF. Indeed, cholera, it's like we are accommodating this disease. Sometimes back it used to be considered as an emergency, but the last episode that we have had, from the moment we heard of Karen wedding, to which was the Weston, and then it continued, and then it went to the forces. Up to now, we are still admitting. Even this day of 24th of November, we are still admitting. So emergency ward of Kenyatta Hospital dealing with cholera cases is still very active. It has never closed. So even me, there's a time I was asking, are we like kind of accommodating? Are we accepted to be living with cholera? I don't know, for whichever reason, public health probably, I don't know, it has given in, or whichever reason, they are really not responding. And to me as a social worker, the way I look at health actually does not start from, it doesn't start from the hospital and end at the hospital. Actually, when we are told that we have the highest, every citizen has that right to attaining the highest standards of health, it doesn't necessarily mean that it's limited to the hospital. It's all around, in the sense that is every citizen protected from being prone to accidents? Yeah. Are they in good nutrition? Do they live in the right environment? Yes. Are we protected? Are we secure? Because again, if we are not living in that kind of setup, sincerely speaking, you cannot consider yourself as living a healthy life. Yes, because if you get an accident, like I'm sorry, the late governor of Nyeri, he was healthy, yeah, till only a few. Can you consider a few maybe minutes to hours, and he passed on. So the health is not about being admitted and being treated and going. Okay, in the event that probably we get sick for whichever reason, then the curative part of it, we should also be able to access it, and it should respond to our needs. But I consider a well society to be a very productive society. It doesn't make sense when we are nursing so many people in the hospitals. It doesn't make sense. Yes. So well people, we are better off having well people being productive and producing more to the society, taking care of their homes, their children, and supporting each other, as opposed to nursing very sick people in the hospital. Let the people who require inpatient care or even outpatient care be brought to the very minimum. That's my way of looking at things. Yeah. If we could invest more in public health and in these other aspects of life that makes us be prone to losing our good health, then it can be better for us. And the issue of NHIF is very, very sensitive. It's very political in nature. You saw what happened just the other day. Yeah, they wanted to limit the visits to 4 full visits in a year. That was they speak in a very inhuman way, because nobody actually can indeed, you cannot be able to predict when you are going to get unwell. Yeah. So even when they responded to it, when the cabinet secretary responded to the same issue, well, it was put on hold. But NHIF for sure, as at now, I think probably we need to do better. Yeah, so that with the cooperation between the health facilities and the NHIF, probably we get to see how best to take care of our clients. Thank you.
Before I let Dr. Joya speak, we have an announcement. There's an audience member who wants to go home, but there's 2 cars that are blocking her. So if you have the car KAX958B or KBA 737P, please move your car, because there's an audience member who wants to go home. I'll say it again: KAX958B and KBA 737P. All right? Thank you.
Okay. I want to respond to Yust's comment on whether Kenya is capitalist. That is an ideology that was fed to us by the Johnston administration. Sorry, I don't use the Kenya for their names anymore. From the 1970s, and it was an explanation for the injustice and inequality in Kenya just after independence. But what that did was it made Kenyans accept it fatalistically. Kenyans have not really examined what does it mean to be capitalist. They say it fatalistically, like there's nothing they can do. And how do I know we are not really capitalist? We are actually feudalists. And feudal means that the country is governed by landowners. They have power because of their access to land. And in feudalism, anyone who lives on the land is owned by the landlord. So what has happened is that tribal kingpins have become landlords, so they own their tribes. So tribes cannot think outside what the landlord wants. So that's what we have. It is not capitalism, it's feudalism, and that's why I always talk about land rights being central to revolution in this republic. But on top of that, we are not capitalists because there's a very strange phenomenon that we expect philanthropy from politicians, which is different from the US, where philanthropy is something you beg for, which you're given out of the goodness of the rich person. But in Kenya, it is demanded. So if you are a rich relative or a politician, people expect you to donate. It's not a choice. So, but the problem with that kind of donation is that it's moral. So what we have basically done is that we're expecting public services out of morality, not out of a political demand. So that means when somebody is sick, people will call you and say, your cousin is in hospital, you have to donate. But it's not a choice. You have to, or else you get curses, or people won't come for your wedding. So that's the problem. We are using family blackmail to get social services instead of doing this politically. So in a sense, what is needed is to elevate Kenyans' understanding of politics. And politics means distribution of public resources. It does not mean who is president and what tribe is he. It's distribution of public resources, and that is something that Kenyans need to change, and that falls back to the education system, because the education system is beating this acceptance into children from the very beginning. We use a lot of violence in our schools. If it's not physical violence, it's mental and social violence. So by the time kids are leaving the high school system, they have been taught not to question. So the whole system is so screwed up, and we have to fight multiple fights. For me, it's education and healthcare, but if the unions want to fight 5 of them, let them fight 5 of them, because this thing is so big. We have to fight on multiple fronts, unfortunately, and hopefully we will all come together somewhere, but we can't not start fighting because we want to wait to be organized by someone. The other problem why we think we are capitalists is because of our religiousness, because socialism was connected to atheism, and because Kenyans are so religious, they don't want to be connected to socialism, even if in their private homes they are demanding some kind of socialist service. So we are demanding that society must take care of us, but we don't want the label socialist, because to be socialist means that you're an atheist and you're not a Christian. So the strategy, and that's why I mentioned the religious society, the strategy to convince ordinary Kenyans to embrace this kind of political thinking is to go through the church and through African traditions. Unfortunately, we have to be more innovative in showing how Kenyans do accept an idea of welfare state, but not with the words of the West, because if we use Western words, Kenyans will immediately say, oh no, we can't think like Cuba, they are communist and they are atheists. That's the simplistic thinking of Kenyans. So and I agree with you that rights is not working. The language of rights is not working as a way of helping Kenyans understand and accept the importance of healthcare. So actually, one of my most shared posts was when I said, I'm not paying for Harambes, and that shocked people. I said, I'm not paying for medical Harambes anymore, because I'm trying to talk about public health care. You have accepted that public health care is bad, but then you inbox me asking me to contribute for a hospital bill. I said, I'm not doing that anymore. And people shared and shared and shared. So you see, that appealed to the Kenyan conscience, because we are used to demanding social services through relatives. So if a relative says, I don't care, don't ask me for money for health care, then they get shocked. And maybe that's one way in which now to push the idea of the welfare state. Another time, and I wrote this post, I said, I'm not tithing anymore, and I've actually stopped. I said, I'm not tithing anymore. Any contribution I make to healthcare comes from my tithe, because the church has refused to talk about public healthcare. They're even borrowing loans. Imagine. They're borrowing, NCCK borrowed a loan to build a hospital. What is that? And then we are tithing. So I said, I'm not tithing anymore, and I've stopped. So I said, anytime I give a contribution for healthcare, I am not tithing. So imagine if all Christians, and we are supposedly, let's say about 50,000 Christians in Kenya, in Nairobi, did that, the church would stop being so complacent and telling us that healing is a healthcare insurance. It's not.
Thank you.
Because I have to leave, I've been in the public healthcare for 17 years. So, a lie often repeated becomes the truth. Yeah? And this lie that doctors did not push a health service commission has been repeated so many times that even that guy believes it's the truth. If you go to one of my Facebook posts, you'll see the health service commission in the 2204. That's the time when we were even making it there. The health service commission was removed between where we had not, it has reached the end. This was called committee of experts. Between committee of experts and parliament, it was removed. I suspect some money changed hands. But it was put that someone could bring it out as an act of parliament, and it was actually put in the Hansard. Yeah? So when Mwai Kibaki in February 2013 devolved health, he devolved it correctly. The reason we are having cholera is because health, primary health was devolved to the governors. They were supposed to do that. They were supposed to stop cholera. They know all their people. They were supposed to run primary health care. That was the correct devolution of health. What is called referral health facilities was all the hospitals from level 2 to level 5. Come the elections, Jubilee won in 2013. In June, the governors realized that there is no money in the county other than the money collected in hospitals. Therefore, they forced the president to unconstitutionally devolve health. And the president said, oh, no problem. He knows doctors are a problem. So he said, take Chukweni. But he did not devolve MES. It's called MES was a managed scheme, as in anything with procurement remained at national level. It's very easy. So devolve the health workers. So in August, Transitional Authority, which I contemplated suing, unconstitutionally devolved health. They did not remove the real health devolution that was done in February, but so it became a fight. KMPDU went to court. The judge dismissed them. I went to court. In Justice Lenaola said he could not interpret what these national referral health facilities was. Therefore, everyone assumed that health is devolved, and everyone quickly ran. And that's why we're in this mess. There were 43 strikes between 2013 and 2017 because people refused to follow the law, is what we call unconstitutional devolution of health. So the Health Service Commission is there, but it's often repeated that doctors did not push doctors. We did, and it is there. It's written. It's in black and white. But political will, the governors cannot allow the money in health not to be in their hands. And that's why currently, if you go to a hospital, the medical superintendent is just a useless fellow. He controls no money. Previously, the health HMT, the hospital management team, managed hospitals. And if you look at the report of hospitals from 2007 to 2013 in what is called reversing the trends of health were reversed because the hospitals managed themselves and they became and that's why in 2013 the governor saw so much money in the hospitals they couldn't believe that they could not, but they were supposed to solve cholera. So unconstitutional devolution of health is our problem. We are not following rules. We are being led by politicians. So when the politicians say this, devolve that one, they should devolve. And as I said, a fight between the politician and the doctor with the public, the doctor is always wrong. The politician will always win. So that's where our problem lies.
Thank you very much. My name is Dr. Jeremy. I'm here on behalf of Emergency Medicine Kenya Foundation. We partnered with Rock pictures to do the 18-hour movie, which I hope in the end we'll see the trailer. And our focus mostly is emergency care. And I'm here as part of the solution. It's something we are doing as a foundation, and I would like you to know about it. One of the things, as Afrani had asked, is how many of us know a number to call. And there are very few of us in this room who know. And one of the things we are pushing is in part with what my colleague and my secretary said about universal health coverage. We are trying to push for what is called universal emergency care. And what we want to see in the country is that wherever you are, one is that we have a short code. Like if you go to Europe, call 991, 911, they will come, they respond. We saw what happened with the governor's case. Like some of us, specifically Dr. Wachira, who is my co-director, he got to know about the governor through social media because someone had posted on Facebook. So we don't have a system where I can call and it's coordinated. So we've worked out, we've actually come up with a plan where we are pushing the government, we are pushing to see that NHIF will actually cover, because that's the only way to access social coverage. We can't think of any other vehicle to help us with this, such that if I get an emergency, actually what the Constitution says is that every Kenyan has a right to emergency care. But what is emergency care? So we've gone ahead as a foundation and defined what is emergency care, and we're trying to roll out this and giving it a cost such that NHIF will actually cover this, and it will be something which can be reimbursed. So you can go to our website. It's we are the Emergency Medicine Kenya Foundation, and we are talking more about emergency care in the country, and we are trying to see how we can be a solution to the country. We believe that we have the solutions. Actually, Kenyans head most institutions in the world, and we believe that even as a country, we have the local solutions. Thank you.
I'll get back to you. I just have a question out of curiosity. How many people in this room, by a show of hands, have NHIF cover? Oh, wow. Okay. I know I asked that question because... Oh, you too, yes? Yeah?
Yeah, it's part of my job.
Okay. The reason why I asked that is because, so as I said before, I do public health research, and some of the research that I do is in relation to NHIF. So obviously, if you're a former employee, your NHIF is essentially covered, and private health insurance, if you're offered that too. If you're in informal populations, if you don't have a formal level of employment, NHIF is voluntary, so you don't necessarily have to pay in all the time, but if you don't pay, you don't get the cover. But statistically, between 17 and 19% of the population has health insurance, public and private, meaning that over 80% of the population do not have health insurance. That is deeply problematic. So when we're thinking about this and we're thinking about how we need to rehumanize the debate and how can we bring, universal health coverage to Kenya and make it a reality, we really need to think about those statistics. 4 out of 5 people do not have health insurance, meaning if they were to have a heart attack at this moment, it is not guaranteed that they will be treated. That is problematic. Okay, so I really want you guys to think about that while we're having the discussion. So, yeah, I'll pass on the mic to Brian.
Okay, before Brian, I have this gentleman. I forgot about you. I'm sorry.
Thank you. I'm Mashangi Nyaga from Mathare Social Justice Center, and I am a coordinator in the campaign against extrajudicial execution and environmental degradations. So I've been in the community working on like a community health worker
of which I was, due to my activities of advocacy in the community, I was called by the administration, that is the chief of the area, and given other peoples, I don't know where they were from, but they told me they were from Kenyatta Hospital, among other hospitals. They trained us on how to mobilize people to come and get services, free services. So my question is, in Mathare Social Justice Center, we do document issues. I've heard people talking of cholera. Cholera is not in Runda, is not in Kilireshwa, but when you come to Mathare, where we stay, cholera is a lot, in a big number. Why? Because in our documentation, we document on people lacking water, people having staying in houses where sewage just pass outside the door, children praying there, eating food outside there. So it's eco, in kitu eco, it's just sin. But now the thing is, like me, I'm a socialist. The thing is, on the issue of unions, what is the role of unions in making sure that the normalization of violation of right to good health of the public, why is it not advocated from the union up to the grassroots level, or from the grassroots level, and then the union just have a platform of the grassroots level? That's one question. And in my office, we do have people coming, because people come and say, hey, Zangi, me, I'm called Zangi in the mta. Zangi, my people in Kenyatta have a very big bill, and we are not able to pay, because you'll find the families of street people. We are not able to pay. Now, what do? Should we leave our person in the Kenyatta? So may I tell them, there are social workers in Kenyatta Hospital, so maybe you can go and try to talk to them. But when they go to Kenyatta Hospital, the social worker, what is the response of the social worker? The social worker said, tell them, go search for 3/4 of your, and then the person come again, say, oh, 3/4, even I don't have a quarter of quarter. So it becomes this issue of normalizing this violation is a big serious problem, a problematic thing. So what should we do as unions? Because we may believe in socialists, we have to empower the proletariat persons, the working class people, so that at least we can be able to combat the capitalist system, of which has made all this neo-colonialization, neoliberalism to be what is only just thing going on even right now. So my question is to the union and also to the social workers. What should we do? Should we, like a good example I'm giving, in extrajudicial execution in Mathare, it had been normalized, and people were just shot, and it was, he was sour. Evil. But now we started creating a story, people to discuss this thing, because if people don't discuss this thing, then the capitalists take advantage of that. So we started discussing this thing. Why is it? Is it a right for people to be shot down? We go to the constitution, people have the right to life. So why don't the union, why don't the health workers come together and go to the grassroots? Because when you go to the chief, I know it's because of the system, when you go to the chief will just mobilize his people, and the people like-minded to do corruption, and they'll do whatever they do to make sure that the agenda of the government, we are reaching people and people are participating, just go on, but it's not the real thing. So what should we do? May I believe, I'll try to answer for you. What we should do, we should come and try to, we should come together in the grassroots level as unions and try to come and start making this thing that people have the right to good health care. People to start speaking about it, to have discussions. These documentations that are documented by grassroots movements to be also referred to other organizations and be pushed, even if it's in a matter of court thing, so that also, like my comrade is saying about held something of commission, it can be, the government can see and see, oh, so we need something like that, like this, to be also like an oversight of health issues. Thank you.
it? Who wants to address it?
Thank you very much. Very passionate discussion, and I like that. A few months ago, I was sitting with the public health officer, the medical officer, public health, and we started having the discussion that is just mentioned. How do we make people aware that healthcare is not just a right, but it's something that they need access. They are actually entitled to quality healthcare. The rights versus welfare. I'll tell you for sure, rights are not given. Rights are fought for. Rights are fought for. If you go to Sessional Paper 10 of 1965 of Kenya, and you read that paper, and anyone who's here, take time today, go download it and read it. You'd be amazed at what you're seeing, what the government was trying to discuss. What the discussions we're having right now is what was in that paper. But the political will veered us off that path. Feudalism, corruption, all that. To date, years later. So I'd like to merge your question with when she asked, how do you build a civil society for healthcare in Kenya? I think he's already provided us one solution. There is need for every organization, from us, the trade unions, from people like Wandia, from John Githongo, who talk about corruption, because corruption even comes to health. We've seen the biggest health scandals in this country in the past 1 year. We need a platform, and this is a beginning of a platform. This should not be the end. We need a platform, emergency services. We need a platform where all these issues will be discussed, and from that, we have a team together, just us to do that. Otherwise, we might be fighting from all fronts, but then there's some level of disorganization. We need to synchronize all our efforts. And the day that we will make the public, at the grassroots level, my friend, the day the public at the grassroots level will understand and grasp this as the way he's bringing it out. You have people out there like him advocating for healthcare, quality healthcare, is the day we'll have change in this country. Health Service Commission, there's no two ways about it. We need a referendum. We need a referendum. And if we need a referendum, then it means the civil society for healthcare that we're talking about is the one to initiate it. Let's just forget that politicians will initiate this. They will not, because of their interests. I'd also like to touch about, so for the unions, our task is set out, I think. We are trying to expand our wings to also involve the grassroots level, because it's patients we deal with and they're affected. How human resources for health, unity in the health sector, is it achievable? Your question where you're trying to see if can the unions come together. We are trying to merge a federation of the unions, especially in the healthcare sector, to push forward. And one of the topmost agenda is that Health Service Commission. So we're not sleeping. The political climate has not helped us this year. So essentially the year is gone. But beginning next year, it's an agenda that is topmost for us as unions. In closing remarks, healthcare as a cost versus healthcare as a contributor to the economy. That's one of the discussion points that we need to have, and we need to make our politicians and the government understand. Health insurance, NHIF. Let us not discredit the NHIF. I look at the NHS and I say that the NHIF has a potential to be like the NHS. Because health economics, wherever you discuss health economics, World Bank, WHO, you talk about financial risk protection, that is universal health coverage through financial risk protection and risk pooling, which is what NHIF is trying to achieve, where you pay a premium, but then you're able to access more than what you paid for. There are interests, of course, in our country as usual, and the root of it is again corruption in NHIF. So you see, everywhere you go, you still have corruption with you. It affects every section of every sector in this country. So the NHIF, let us not discredit it. Let us make noise as much as possible. Like the noise that came out, I like what the era we're in. Social media is what sets the agenda. For the NHIF, let us demand more from NHIF. Let us demand that it is made better. Not just for those in formal employment, even for those in informal employment. Like when he talks of people from the slums, I totally understand what he says. Because where I work in Mombasa is a facility that the biggest catchment area is slums. And the people I see suffering there, it's just too much human suffering. We need to emergency services. I like what you're saying, and I'd like to also remind everyone that the Health Act, we've never had a health law in this country ever since independence. The only had is one that was the health bill that was signed sometime in March, and it has now become law, and emergency healthcare services are entrenched in it. We still need, through that law, to set up a mechanism for emergency services. And emergency services go hand in hand even with the infrastructure in this country. Health infrastructure. MES is a good initiative, but it has a problem. The human resource aspect has not been handled. The Beyond Zero campaign. If you look at the Beyond Zero campaign keenly, it was a very good initiative. But you know what the problem is? The trucks were lying in the facilities. They're not going down the villages where mothers are unable to access healthcare. Why? Because of human resources for health. So essentially, every project that comes out from government, there's an element of corruption in it. And so the element of corruption is that we will procure and make money, but then it will lie there. The trucks were lying. They're not moving. MES, you have CT scans. You have MRIs installed, but they're not functional. Why are they not functional? Because the machines cannot operate themselves. So now, this is taxpayers' money that is being used. But what are we as Kenyans talking about? Are we interested in accountability? Because that is where the buck lies with us. And I still say the buck lies with us. This to me is a beginning of what needs to be done. The last point, our health indicators have gone really down. There's a research that was done, a survey that was done by AMREF, ANC services, that is for the pregnant mothers, from almost 3.9 million to 3.5 million. So about 400,000 in that period of the strike, January to July. Mind you, we're in November 24th. From 2017 January up to now, we've only had 2 months of full functionality in the public healthcare system. 3 months of the doctor strike, a month of work, 5 months of the nurses strike. This is the second month from 6th of November, 3 weeks only. So we have a problem. Immunization coverage has dropped down deeply. These are problems that we're going to see in the next 5 years. Polio, measles, all these will come back. So healthcare is not a cost. Healthcare is a big contributor to the economy. And that's where we need to start agitating from. And I believe a civil society for healthcare is possible. The change begins with us. It's upon us. All these voices, we need people like Sarah here to keep organizing for such forums. So that now from that we have a team doing that work. Basically that. Thank you.
Sorry, before we carry on, there are 2 cars blocking 2 people.
My mom always says every time there's an African event, there's always 2 things that happens. Yes. One is that there's food. There's always food. The second thing is that there's always cars blocking people. So it's not an African event if there's not cars blocking any other people. So first car, please listen carefully. KCN 182A. And then KAX 958B. I'm going to say it again. KCN 182A, KAX 958B. If those are your cars, please move them. There's an audience member who would like to go home. Thank you.
Okay.
Yes, one more thing. We're running over by quite a bit of time. Another thing that African events do. So what we're going to try and do is give just 10 more minutes, because I know there's probably a lot of people who have questions, and then we finish bang on at 9. Is that okay with everyone? Is everyone happy to continue the discussion? And then we also have refreshments, so you're most welcome to stay and talk over. I saw someone say, yes, we have refreshments. So yes, you're more than welcome to talk over the discussion at refreshments, okay? Thank you.
Thank you. Before I get to answer Mr. Nyaga, I would like to pose a question to the people who are participating in this room. How many of us would consider to seek medical attention at Kenyatta National Hospital as their first choice? Yes. Did we get to the question? Oh, they have already answered. Okay. Okay. But if that's the case, how come Kenyatta Hospital is always overcrowded with patients? Why is Kenyatta Hospital always full with the patients? If none of us would prefer that hospital to be the hospital of choice. Why is it that we have so many queues at casualty? Where did the patients come from? And yet, it's not a so good hospital, in quotes. Okay, what I'm responding to when I posted that question is that indeed it's very true that Kenyatta does address the issues of the needy in this society. That's why Kenyatta always has high population of patients. And these patients, in most cases, you'll find that they have started from private hospitals when they had money. Yeah, when the money got exhausted, the very private hospitals refers them to Kenyatta Hospital. I think we are communicating something. Yes, so Kenyatta Hospital becomes a dumping place when money is exhausted. That's why we always have very, very complicated cases at Kenyatta Hospital. And point number one, which will always come out, inability to pay the hospital fee. Why? Because they have exhausted it somewhere else. Yeah? And now they come to Kenyatta Hospital because they don't have any other way. Maybe that can take me maybe to take you through what has happened like the last 3 months. In the month of August, Kenyatta used 61 million. September, they used 49 million. The month of October, just last month, we used 62 million. And in November is yet to end, but we are already at 50 million. Yeah, the money that we have spent on the needy patients. This money is never refunded by anybody. If Kenyatta Hospital management was to seek help from Treasury or from Parliament, they are told, develop mechanisms on how to recover your debts. It's not our problem. It is your problem. So then what happens? Indeed, Kenyatta is the highest referral hospital in our facility, takes care of Kenya and the south of Sahara region and all that. Yeah? And then with us, when we receive the patients, money doesn't come fast. It's a treatment that it does come fast. And then in the back of our mind is that when we continue the treatment, the family members should be doing something about the treatment to come and do the payment later. But many of the times when we are through with the treatment, when it comes to the bills now, the family responds by saying, we don't have a medical cover, yeah, and we cannot pay. So can you give us help? Yeah, and indeed that puts Kenyatta Hospital at a precarious situation whereby they have to make choices. And for sure, Kenyatta, being an autonomous institution, they have been given a mandate to run their own operations. So they came up with a credit policy, which I think Mr. Nyaga could be aware of, whereby the patients are encouraged and their family members to pay as much as possible. Yeah? For instance, if they make 3/4 way of the payment, they have assisted the hospital to run. But in the event that that cannot happen, still, every client's needs are tailored. is not a cast on stone. The social workers do the evaluation on admission actually, or 24 hours, we should have known who our clients are and their mode of payment, whether they have the medical covers or not. And if it's cash, we are able to know the support system of our clients, how they are likely to respond at the end of it all. And then the social workers do not only respond to money issues. As I had said earlier, we respond to so many issues that pertains to the patients. But what stands out in most cases, when a person talks of a medical social worker, they are talking about finances. Yes, and it's very true that when a patient does develop a medical condition, it's very draining in terms of finances. It even actually brings the family finances down. Yeah, the condition, the medical condition, usually brings poverty to the home. And as my doctor one year had put it, that in the African setup, many of the times we are forced to pay not because of our own, not because of our own will, but we are forced to pay because we don't want to be ostracized by the family members. So in a way, for you to fit in the family, you have to oblige and you have to respond to that. But the welfare system actually is supposed to come from the state. Nobody is supposed to compel another family member to take care of your own issues. But then the states that have been known to develop well in the provision of welfare services to their citizens, there is a history that they have very low, almost zero corruption, like the Scandinavian countries. They invest more in the welfare, and the people, they are able to work and produce more, and actually that's why and that's how they get to develop. But when it comes to poor countries and developing countries, I'm sorry, ours is a developing country and a poor country.
A poor country.
I think our country is a poor country. That's how I see it. That's as a social worker, because we are poor in doing everything. We can't manage our resources. We can't do, even at the family level, we can't take care of our children. We abandon them. We can't take care of our sick. We abandon them in the hospital. We are poor in every aspect of our life. That's how I look at our country. We need to improve on that. We can do better.
Okay, now today my brother has gone, but I've decided I'm going to come out of the closet and stop hiding that I'm a socialist, because I think if we were more vocal about it, it would be good. I just wanted to say one thing, and I'm sorry that the doctors are not here because this was addressed to them. Where are they? Oh, no, I'm saying the gentlemen who are here, not because they are doctors, but because they are saying that the problem is lack of political goodwill. That's not the problem anymore. Lack of political goodwill ended in the 90s. Now our major problem, is the corporations, because they are funding the politicians, they are funding the campaigns, and so it is very difficult for ordinary wananchi to hold them accountable, because once somebody is elected, quote unquote, they owe their loyalty to the people who contributed to their campaigns. So it is the corporations, sorry to say, that are now our biggest problem, because they are the ones who are holding our politicians by the puppet strings. And that's why I'm sorry to say, but the boycott really is a step forward, because we are now starting to hold corporations accountable for what they are doing in Kenya, and that should be part of the healthcare conversation, because they are part of the people who precipitated this crisis.
Another car? Okay, so there's one more car, KBM 536M. KBM 536M. If you have that car, please move it. There is an audience member who'd like to go home. We're going to take one last question, and then we'll break for refreshments and networking.
Good evening. I'm Brian Odhiambo. I'm a paramedic by profession. Now, mine, I have questions or comments, but the way they will come, just take them the way they come. Is it okay? Yes. Just a minute. So now, one of the things that normally disturbs me as a medic who's practicing is that what responsibility do we have on ourselves against the patient, or the way we put it, the client? When you get a client who's in critical condition that needs emergency care, or that might need advanced care, what is my responsibility? You know very well that this patient might not be able to afford the level of treatment that is needed from your view as a medic. Doctors, you know that, right? You need a CT scan, but then you know that this patient may not be able to afford the CT scan. What is our role in terms of that? Still on we as medical professionals, do we really encourage most of these things that we are talking about now to our patients? Yes, we are talking about them right here in public. It is live streaming, but do we really tell our patients that go take insurance cover? I personally do, but do you? On a daily basis, I meet patients. I personally worked with St. John Ambulance before I moved to the emergency care. There, we used to go into really deep into the slums, sometimes in Madara, sometimes in Kibera. What you see there is the reality of what we are living in. Leave alone what we are doing right now, but that is the reality. Most of us are to gender pale. So, now, another thing is that, do we really tell our patients their rights? Because telling a patient the right, of which apparently is not working, but we can be a patient the right, that might work against you to some extent, we as medical providers. Am I lying? It might work against us, but what is our responsibility? Should we or should we not tell the patient the rights? We should. So, I don't know how you're taking that, but ni ukweli. And now, another thing that caught my eye is the late governor's death. Now, this is something that is still so fresh, but let's look at the discussions that came after the death in terms of politics. The first thing that happened, the first, okay, me personally, I saw it on Citizen TV in the morning, but then in the afternoon, there was a governor's conference where Mike Sonko was the one who was addressing it. But then what the issue that came out was we should investigate the death of this patient, of our governor. And then later on, the one who was just been sworn in said that this car was faulty. None of the politicians has talked about emergency care on our roadsides. Am I lying? True. What does that show us? It is much more of political interest than the reality of the matter. Another thing is the public resources. That one is was well covered by Mr. John, who said that corruption will, as long as there's corruption, let's expect tusitarajie mingi. Because Madam Bahati has said it very well. The more the corruption in a country, the less the services we will get. True. Corruption is a thorn in the flesh in Kenya. It has been there. Just on the other day, Churchill, on Kids Corner, mtoto aliulizwa, what is Kenya proud of? Akasema corruption. What does that show? It is there. Now, let's talk about public knowledge and sensitization. Now, again, this brings me back to my first point. The doctors and the other healthcare providers, me as a medic. Personally, we come into contact with these people on a one-on-one basis, but we really do that. Now that we have the KMPDU board, we have EMSK, we have the panelist, does it really start with us? And now, the media and film. Let's talk about media and film. Thank you, Bonabila Fani, and your group for making the movie. It goes out a long way to help the society. But my other question is, we as young people, when you go to the media, what do we really champion for? Right now, for the past 6 months or so, it has all been about politics. Very few people talk about emergency care. Very few people talk about the movie. Very few people talk about what is really disturbing us. We talk about what is not disturbing us. Politics. Personally, politics does not affect me in any way because I don't believe in politics in any way. It only takes us inatupeleka chini day in day out. Kila siku we go down and down. So now let's look at my last point. Okay, not my last. Yeah. Now there's an app, the Flare Services. I was going through it, and then there was an article on BBC about it today. Now the article, I just quote a part of what was written. What was written is that by Dr. Stella Bosira Otieno. She's one of the KMPD board members. Now the doctor says that it is a really good initiative, but will it really work to the down people over there, because we need to subscribe to it. Those are the questions that she raised. So, I thank you.
Okay, I'm just wondering, did the panelists want to respond to those questions? Did anyone have a pressing answer to the questions? No? Do you have one comment? Okay. Okay, before we close, we'll give it to you.
Okay, I will just two comments on what was raised about trade unionists, but I think it will take time to teach Kenyans what trade unionism is. Trade unionism is activism. And the way we are registered by the ministry, we have specific mandates. Like now, the question which was asked by our friend from, was it Madari Ama from somewhere? What we are doing, Mr. Nyaga, what we are doing about the rights down there. We cannot directly come there, but we are partnering with human rights, like the currently, the just ended nurses strike. We partnered with human rights, the fielder, because mothers down there are the ones who are being affected and the children. So we cannot directly come and confront on the issues on the ground, but we also partner with other institutions to make sure that the rights down there, the citizens get the rights down there. But we cannot come as a nurses union and start saying there is some violations in the community, because we have limitations. But we have a way of partnering with the other institutions. Another request I would like to make it to the organizers of this panel, maybe they can include the implementers of what we are proposing or we are putting through. Maybe they can be part of the panel, so that at least they can give answers, not us giving solutions to ourselves.
Thank you for that point. Actually, one thing I forgot to mention at the beginning is that we did actually get in contact with the Ministry of Health. We got in contact with the NHIF, but they all declined. So we did try and get implementers involved. We tried to get people who are, representing the government, county governments, but they just did not respond. So we tried, but what can we do? Yeah, we tried. But maybe next time we'll push harder, because it is important to make sure that our voices are heard. This brings to an end the panel discussion. A round of applause for our panelists, please. Thank you very much to the panelists for your insight and contributions. Thank you very much to our special guests. Thank you very much to all our audience members. You have been amazing. One thing that I really have to reiterate, people who know me well know me for this. I love impact. I hate talking about stuff and then putting it on a shelf and then not talking about it ever again or not doing anything about it. You being here has shown to us that you have an interest in this topic, you have an interest in this issue. And for those of you who are already working to make changes in healthcare, thank you very much. I know that a lot of times you aren't appreciated. We appreciate you. Thank you so much for making a difference. For those of you who are thinking about making a difference but haven't yet made the first step, why? Why not? Why not now? Why not today? You have a network of people here. And in future, if you go to other events, you'll be meeting other people, and I'm sure you have ideas. Don't be afraid to implement them.